Yes, sir.
Okay.
Dr. Ajish Paul finished his bachelor's in dentistry from Amada School of Dentistry in the year 2010 and completed his master's in periodontology from Mahatma Gandhi Postgraduate Institute, Pondicherry University in the year 2015. He is into general practice from 2015 at Alva with special interest in periodontics and implantology, biomimetic dentistry, soft tissue and hard tissue augmentations, and also oral rehabilitation and aesthetic dentistry. He has also established a dental lab specializing in indirect composite restoration, first time in Kerala. Currently, he is practicing as consultant periodontist, implantologist, laser dentist, and biomimetic dentist in Believers Church Medical College Hospital. On behalf of Tiruvalla IDA, I welcome you, sir.
Thank you.
Okay, doctor, you can start.
Yeah. Good morning, all. First of all, I would like to thank Dr. Simon and Dr. Ravi for inviting me and giving me an opportunity to share my ideas and learn from all of you general practitioners. See, I'm a periodontist, but I'm into general practice for last 5 years. So this is not going to be a talk about periodontics, but this is going to be a talk about from the point of view of a general practitioner who practices perio in his clinic and in consultation practices across different parts of Kerala. So there's a slight issue here. Actually, I was having some difficulty with entering the Zoom. So the presentation is being operated by the coordinator. It's being there may be a slight delay. Please. Anyway, we are going to start. Okay. So as you all know, sir, can you put the next slide? Yeah. So you can see a picture of Burj Khalifa here, Burj Khalifa. So, you know, in order to make a huge structure, how much huge and strong or how much beautiful it is outside, it needs a very strong basement. So on the right side, you can see a castle, a sand castle. See, even for a sand castle, a very broad basement is required. But again, the basement actually determines, okay, see how much ever you can give a beautiful FPD, you can give do a lot of aesthetic modifications for your teeth. Okay, but unless and until the basement is strong, it doesn't have a longevity, it doesn't serve the purpose. So the perio foundation forms the foundation, forms the base. Like so. Next slide. Yeah. So we talked about periodontium. Periodontium, as all of you know, it consists of the following structures. It has the gingiva, which covers the periodontium, which you see it from outside, and you have the cementum, which covers the root surface, and you have the alveolar bone, the outer surface of the alveolar bone, and both these hard structures are connected by a periodontal ligament. That is a difference between an implant and a natural teeth. See, these teeth are not actually embedded in the socket, but it is actually tied on to the bone. It's something like a ligament attaches between your bone and the tooth, whereas an implant is actually ankylosed in the bone or integrated with the bone. Next slide, sir. So a periodontist deals with all this periodontal structures. Okay, so to make it very simple, you know, when a person gets periodontitis, the tissue response can either be recession or a pocket formation. Okay, so see, this is very simple. Actually, if you understand this concept, it is very simple. Whenever you have a thin biotype, the tissue response will be recession. And the tissue responds to inflammation by receding of bone and the soft tissue along with it. Whereas a person who has a very thick biotype, the tissue response to inflammation will be a pocket formation. So the main idea behind periodontal treatment is this pocket elimination. Why the pocket need to be eliminated? The pocket consists of inflammation which can't be controlled normally, and something has to be done to control it. So the basis of there is nothing more about perio. It is just this management of pockets. Okay, and one more thing. What constitutes a pocket? It has, I told, the periodontium consists of the cementum, the alveolar bone, and the periodontal ligament, and the sulcular epithelium, the inner wall of the pocket lining or a natural sulcus. So you will have deposits everywhere, or you will have inflammation everywhere. You will have hard deposits on the root surface. You will have inflammation around the pocket lining, and you will have deposits in the pocket, and there will be bone destruction and root surface dissolution or deformation and all that. But the core of periodontal treatment is nothing but removal of the hard deposits which are present on the root surface, which it can be seen outside. We call that supragingival deposits or supragingival calculus, or it is concealed inside the pocket wall, which forms the subgingival pockets. So the basis of periodontal therapy depends on this root surface debridement. We call that root surface debridement. See, early we used to tell root planing, means after the subgingival calculus is removed, either with the use of hand instruments or other instruments, we actually smoothen the root surface. The idea was to remove the disease cementum, and which may help in reattachment of periodontal ligament. But the current concept just sticks on to root surface debridement, means either non-surgically or surgically. That means by opening a flap, you remove the deposits on the root surface. And again, curettage was outdated long back. I mean, we were still doing root planing. Now also it's being done, but personally, I don't do root planing. I just do root surface debridement. And coming to the pocket wall epithelium, there was we used to do curettage, soft tissue debridement. But now that is also not recommended. Once the only important thing is root surface debridement. If you can achieve it non-surgically, do it. If you are forced, or if there is a situation in which you won't be able to remove all the root deposits without actually, because of inaccessibility or other situations, you can actually open a flap and do a debridement. So these two concepts, keep in mind. Our whole period, see, this I'm not going to talk about a lot of theory and all that. Okay, these two concepts, please try to understand. See, when you have a thin biotype, the tissue responds to inflammation by receding, and when you have a thick biotype, tissue responds to inflammation by pocket formation. And the motto of periodontal treatment is pocket elimination, and that is root surface debridement, either non-surgically or surgically. Okay, now just this, all of you know the difference between clinical attachment loss and pocket depth. See, when you have recession, the distance from the CEJ to the margin of the gingiva plus the pocket depth makes the clinical attachment loss. Okay, no need to go much into that. And width of keratinized gingiva, you know, you have attached gingiva surrounding the teeth, and once it becomes alveolar mucosa, beyond the mucogingival junction, it is very soft lining mucosa, and above that you have the marginal gingiva. So the marginal gingiva and the attached gingiva together forms the keratinized gingiva. The width of keratinized gingiva is also important. That we will come to later. Next slide. Okay, so there is a small confusion between, see, I am not operating the slide. So actually what we talked about, the keratinized gingiva, comes in this slide. So next slides, please. Okay, and this is another important concept of biological width. See, let's make it very simple. Biological width is, see, you know, you have periodontal ligament, but this periodontal ligament is a connection between your cementum and your bone. And above that, the tissue, the soft tissue, means the epithelium and the connective tissue hugs around the teeth and forms an attachment. When you have a pocket formation, this actually the sulcus deepens and it may reach the bone level, and you have, or it may reach the bone level or below the bone level. But coming to biological width, just think that when you see a normal teeth, okay, the tissue, the soft tissue, the epithelium and the connective tissue together attaches or closely adapts to the root surface. So this forms, most of it forms a 1 millimeter of epithelium and 1 millimeter connective tissue, which together forms the biological width. Okay, so this 2 millimeter is an average value, but it can range from 0.4 to 4 millimeters. And you just don't assume everywhere it is 2 millimeter. But the important, next slide, sir. It is, what is important is don't violate the biological width, or when is the biological width violated, or how can you identify a biological width violation. See, the most important finding is whenever you probe the margin of the gingiva, it will be painful. That is one indication of biological width violation. And you have some, you have a technique called bone sounding, wherein which this has to be done after anesthesia. If the restorative margin, either of a crown or of a restoration, is within 2 millimeter of the crest of the alveolar bone. When you identify, you can identify this using bone sounding, means after giving anesthesia, take a probe and you hit the bone. Through the sulcus, you hit the bone. You'll actually pass through the connective tissue and epithelium and hit the bone. And if you can identify this distance is within 2 millimeter to the crest of the alveolar bone, you may have violated the biological width. Then again, you can take an X-ray and you can see the restoration margin. If you have a crown or a class 2 filling or a subgingival filling, and the restoration margin is within 2 millimeter of the crest of the alveolar bone, then again you can assume the biological width is violated. So it is always what is more important is to identify whenever the biological width is violated. And what happens when biological width is violated? The usual response in a natural teeth is gingival inflammation. You'll have inflammation of gingiva. So don't think that, like, some cases you will do in some cases you will do meticulous oral hygiene, you will do repeated scaling and all that, but then again you will have inflammation. So always think that the biological width would have affected here, especially in cases of FPDs or restorations. We'll come to examples of all this later. Next slide, sir. Now, what will you do to correct the biological width violation? You see, basically what you have to understand is the restoration margin is close to the crest of the alveolar bone. So what are the different ways? You can either move the margin away from the bone or move the bone away from the margin. How to move the bone away from bone? You can either do root reshaping, means the tooth prep margin can be corrected. Okay. Or another way is orthodontic extrusion. There are two different ways to do it. Either slow extrusion, you extrude it slowly. So when you extrude it, the bone will grow along with it. And after that, you can correct it by osseous surgery, osseous recontouring. Or the another way is fast extrusion. With every 7 days, you have to do a supracrustal fibrotomy along with that. Okay. Now, how to move the bone away from the margin if the biological width is violated? See, so you have to see two things. Okay. If the violation is only on the facial or lingual aspect, or the tissue biotype, again you have to see a thick or a thin biotype. I forgot to tell you how to identify between a thick and thin biotype. It's pretty simple. You actually take a probe or an explorer, and you put it into the sulcus. If you can see the probe clinically through the sulcus, through the gingiva, through the tissue, then the patient is having a thin biotype. Or the appearance, the probe is not seen through the outer tissue, then it is a thick biotype. So if you have a thick biotype and only violation is on the facial aspect, go for osseous surgery. Means open a flap, recontour the bone. And if it is a thin biotype, surgery alone may not be sufficient. You will have to augment it with the connective tissue flap later. A soft tissue augmentation may be required. And see, the third point is very important. If the biological width is violated interproximally also, then interproximally, if it is violated, you will have only in such situations you will have to do something about the interdental bone. See, please keep this in mind. Whenever you do a crown lengthening with or without bone augmentation, never touch the interdental papilla. Once you touch the interdental papilla or the bone crest in the between the teeth, see, you can almost always expect loss of papilla or opening of a black triangle. So especially in aesthetic zones, never ever touch the interdental area unless and until there is a biological width violation interproximally, and which is very uncommon. Next slide, sir. Sorry. Okay. Now, what this is another point which comes, which is very important from a general practice point of view. Okay. It's not that you have to treat periodontitis or you have to do bone grafting and all that. What about daily clinical situations which you encounter, like a small abutment? You know, you require a minimum of 4 millimeters of abutment height to give a crown. Okay, means you don't need more. Actually, minimum, if you have 4 mm of abutment height, no crown lengthening is required, because maximum dislodging forces occurs towards the apical third of the restoration. Okay, now this ferrule. What is ferrule? It is a 360-degree collar of crown around the parallel walls of dentine, extending coronal to the shoulder of the tooth preparation. Means the tooth margin, yes sir? Okay, sorry. The tooth margin, below the tooth margin, you should have at least 1.5 to 2 millimeters of sound tooth structure all around. 360-degree of sound tooth structure below the tooth margin. The prosthodontic concept is like the crown tooth margin should always rest at the sound tooth structure. The crown tooth margin should always rest at sound tooth structure and not at any not on any restoration. But this concept is kind of outdated nowadays. Even if you don't get a 360-degree, means around 360-degree of sound tooth structure, that is okay, provided you do a proper restoration under isolation. You have different concepts of deep margin elevation and gingival retraction for such procedures. But provided if you can achieve that under proper isolation, if you can do a proper restoration, even if the crown margin the crown margin rests on the restoration, that is okay. Okay. Now, what you have to understand is, once, see, I'll tell you a very simple way to do a crown lengthening. First, what you do, you take a BP blade, 15 number BP blade, and cut how much ever of tissue you want. Means if you want, I told you, you want 1.5 to 2 millimeters of sound tooth structure, and you want 4 millimeters of abutment. So take a BP blade and cut away how much ever is needed. Don't think about bone getting exposed and biological width getting violated. Don't think about anything else. Just take it out. Now you take a probe and you do bone sounding. Now you will hit the bone. So make sure that you have at least 2 millimeters from the margin towards the crest of bone. Okay. Don't think about this before actually achieving the soft tissue, removing this excess soft tissue, but think about this after this is achieved. Now, once you probe, if it is within this 1.5 to 2 millimeters, you open a flap and do osseous contouring. So the last point is very important. The flap margin should always be closed 1 to 1.5 millimeter above the newly established osseous crest. Otherwise, what will happen? The supracrystal tissues will rebound. Okay. What will be the clinical finding is there will be inflammation afterwards, and all these things I told. So one more thing what you have to understand is there should be at least 1.5 to 2 millimeters of attached gingiva. So you can't do a crown lengthening if you don't have attached gingiva. In such conditions, you will have to do something called an apical repositioning flap, which I will come to later. So only two things you keep in mind. Just cut away whatever is sufficient, then make sure that the crest of the alveolar bone is 2 mm from the gingival margin. Now when you do it, always look at the attached gingiva and make sure that you have minimum of 2 millimeters left. Next slide, sir. Next, so can we have the next slide? Yes. Okay. So again, this crown lengthening, you can divide it into 4 classes. The class 1, this is something we have already discussed, but I will again make it clear. See, class 1, you have sufficient soft tissue. Okay. So soft tissue removal alone is sufficient, means sufficient soft tissue is there. So this doesn't require the need of a periodontist or a specialist at all. The restrained dentist can do the surgery. Okay, and you will not require to open up a flap later, or bone osseous recontouring won't be required. And again, immediate temporaries can be decided at the same time. Now coming to class 2, again you have sufficient soft tissue, but what will happen is you will not be required to remove bone. What you will be able to do is you will be able to do a crown lengthening and give a temporary immediately, but a specialist may be required later to open a flap and do the osseous recontouring. Okay. So next slide, sir. Okay. Now, a third situation, it is like if you remove just the soft tissue, imagine the bone will be exposed. Okay. So along with the soft tissue removal, at the same time itself, you will require an osseous recontouring. So it is best to either a specialist to do it, or if you have the expertise, you can do it on its own. In such situations also, you can do immediate temporaries. And the fourth class is where you will have inadequate width of keratinous gingiva. So what is the option is you have to increase the width of attached gingiva by either a subepithelial connective tissue flap, orthodontic extrusion is another option, or apical repositioning flap may be required. Okay. See, my idea is not to go into the details of all this, just to give you a outline of how to manage different clinical scenarios. Okay, in which you may encounter in your daily practice. Now coming to the next slide. Next slide, sir. See, this is another very, very important thing. Okay, where to place a crown margin or a restoration margin, whether it should be supragingival, when it should be subgingival. If it is subgingival, where should be the margin? At what depth should be the margin? So to differentiate between supragingival and subgingival crown margins. Okay. See, if you don't have a discolored tooth, Okay, and if you don't have any other need to extend the subgingival, like a subgingival caries extending below the gum level, or you have a fracture below the gum level, you have an erosion or an old restoration, which for the complete removal, which you have to go subgingival. Okay, or for the need of post and core and a ferrule, you can always go for a supragingival margin. But when you go for a supragingival margin, especially in aesthetic zones, the choice of material is also very important. You have to go for a translucent material like Emax, lithium disilicate, or indirect composites. Okay, now when you have a discolored tooth or structural reasons, or the choice of restorative material is an opaque material like zirconia or PFM, then always your restorative margin should be subgingival, especially in the aesthetic zone. So this is make this concept here. Two things, uh, the choice of restoration and the tooth color, sometimes a non-vital teeth. Okay, it may if you give a supragingival margin, even if you're going with an aesthetic restoration, it will be of two different colors above and below the crown. Okay, or if you're going for an opaque, or if you're going for a opaque restoration like metal, ceramic, or zirconia, then again, if you have a it will obviously look different. So always go for a subgingival restoration if your choice of restoration is an opaque restorative material. Okay, next slide, sir. Now the next question is, when you're giving a subgingival margin, where to give it? This is actually dependent on the depth of the sulcus. So you probe the sulcus depth. See, sulcus depth, the normal sulcus depth will be, it will be within 2 millimeters. That is a normal sulcus depth. But you'll have an excess sulcus depth either due to pathological deepening, like when you have a pocket, you will have a more deep sulcus, or a more common condition is altered passive eruption. Altered passive eruption is nothing but, see, our teeth will continuously erupt, and once it reaches a occlusion, what will happen is the soft tissue margin will actually recede and go to a level of at least of maybe 1.5 millimeters coronal to the CEG. See, this is a normal physiological process. This is called passive eruption. But in cases of altered passive eruption, what will happen is this gingival margin will not recede to that much level, and you will have a deeper sulcus. This is not pathologic, but this becomes a problem when you give, either it can be an aesthetic problem, you'll have short clinical crowns, or mainly this becomes a problem when you restore that teeth, like when you give a crown for that teeth. So what you have to understand is, when you have a shallow or normal sulcus, means within 1 to 1.5 millimeters sulcus depth, ideally you can go 0.5 to 0.5 to 0.7 millimeters subgingivally. The restoration margin should be subgingival of minimum depth, means 0.5 to 0.7 millimeters. Okay, but when you have a altered passive eruption, you will have a more deep sulcus, 2 to 4 millimeters. So what you have to do is, the problem is, you will think that, okay, fine, this is a very normal sulcus. So why if I just go like the normal way, like 0.5 to 0.7 millimeters into the sulcus, what will happen is, once you give a crown, there is a very high chance for such sulcuses to recede, and the margin, the restoration tooth margin, to be visible later. So again, at such, if you're giving for a translucent, if you're going for a translucent restoration, this is still okay. But when you give a zirconia crown or a PFM crown, in a case where you have a very deep sulcus due to altered passive eruption, what will happen is, in a later stage, there will be recession, and the tooth restoration margin will be visible later. And now the third case is in the case of a pathological deepening of sulcus. Okay, so okay, now when you have a pathological deepening of sulcus, again you just keep it a rule like you go half of the sulcus tub. Suppose if you have a 6 mm pocket, then you go 3 millimeters. Okay, next slide, sir. Okay, now coming back to periodontitis. Okay, now what all are the common questions that you had to ask? Ask. The first question is, does your gums bleed while brushing, biting onto food, like when you bite on an apple, huh? Or when you eat chapati, huh? Or when you spit, especially when you get up in the morning and you spit, okay? Or after eating, you go and spit. Huh? Does your gums bleed? Okay. Another question you can ask is, does your gums feel swollen or bulges appear on gums? This bulges may come and go. This is a very typical presentation, especially in diabetic patients. Okay. Now, another question is, do you have salty or foul taste in your mouth, or if you are you feeling bad odor, malodor are you getting? Okay. So, and another thing which many people will have is, so you ask them, do you feel your teeth have developed spaces in between, or they have moved away from their original position? Some people may feel the teeth is proclined and spacings would have appeared between teeth. Another common thing is food impaction. So I ask them, do you have food getting stuck between your teeth? Another thing is the gums may feel sensitive. The gums or teeth may feel sensitive. Okay. And another very important thing is the patients may feel teeth as loose, or they may feel it as, typically patients will tell, I'll feel feel weak. The teeth are feeling weak while chewing. Okay. Another thing is, does your teeth appear long and roots, or the roots are getting exposed, or does black triangles or triangular spaces appear between your teeth? Another important thing is, you have to always ask, are there any previous episodes of scaling? So sometimes a patient will come to you and you will not see any inflammation there, or any cause for any local factor for inflammation. Maybe he would have gone for scaling very recently. Okay. And always ask them, whenever you ask them about scaling, you ask them, how was the experience? How do you feel about scaling? Okay. Patients have a very very funny this thing about scaling. Okay, many people will tell, I went to that doctor, he did scaling, and after that my teeth started moving apart, all gaps started opening, my gums have receded. So what is actually happening is, all these things have already happened. See, even dentists have this thing. I've seen many dentists, or I heard many dentists saying, oh, no need to do scaling, then such things will happen. There will be spaces, there will be the teeth will appear long and teeth will start shaking. Okay, but what is more important is, see, all these things are happening, all these pathological processes are happening. So sorry. Sorry for that. Sorry for that. Okay. But so what you have to understand is, see, scaling is a very important procedure. So see, the patient has to understand it. It is not the scaling, but the lack of scaling, or their lack of proper maintenance, which has actually caused the problem. Okay. So this has to be made clear before the treatment, or before you start scaling for a patient. Okay. Now, what all are the instruments you need to have? See, you need to have a mouth mirror, of course. You need to examine. Then, see, you don't need much armamentarium for a perio, this thing. what you need is a probe. You can use a perio probe, but my favorite is an UNC 15 probe. It will have a marking on every millimeter. Okay, so why you want this UNC 15 probe? This is to do probing. Okay, the pocket, you have to assess the pocket. Okay, so what is more important is whether when you're probing is bleeding occurring. There can be spontaneous bleeding, or you probe and maybe it bleeds after a few seconds or after maybe a minute also. Okay, so this is something that you have to see for you to understand that there is active disease happening. Okay, so you need a probe, and again you can measure the pocket depth or the clinical attachment loss. Is there any recession? See, what you have to understand is sometimes a patient may have only maybe 2 millimeter pocket depth, but the gums would have receded already to 5 or 6 millimeters, or another side will have maybe 5 millimeters of pocket depth. So which area is more serious? When you have a clinical attachment loss of 8 millimeter, but pocket depth is less. So you have to understand this. But again, one more thing is there. So what is more important is active disease. Okay, you have pocket that has to be treated. But when you have recession, it is more about aesthetic management and management of sensitivity and all that. Okay, but the management of active disease is pocket elimination, or you have to deal with the pocket. Now another instrument which you can use is our common explorer. We call the shepherd's crook, right? So this is actually used to identify subgingival deposits. You can take a explorer and you can feel on the root surface, and you can understand whether there are soft tissue, hard deposits subgingivally. And again, some subgingival margin, crown margin is there, or restoration, overhang of restoration is there. And sometimes you can have anatomical anomalies like enamel pearls, cervical enamel projections, or maybe deep root concavities, developmental grooves. All these things can be identified with the explorer. And if you want, you can have a neighbor's probe. This is actually used to identify the furcation, upper or lower molars and upper premolars. Okay, coming to next slide. Okay, you also have radiographs. Okay, you can have IOPAs if you have bite wings, or if you can also take an OPG to get a one single picture of all the things. But what you have to understand is, suppose if you are taking a OPG, it doesn't have any difference. See, suppose your patient is having recession and no active pockets, or a patient having generalized pockets, or even after a treatment is done, you do periodontal therapy, non-surgical therapy, or surgical therapy, and the patient is being reviewed, and that time you take an OPG, everything looks the same. So just by blindly following the radiographs is not at all acceptable. You have to always clinically correlate your findings. Okay, now you know what to ask, you know what to have, and now what to check. So the most important thing is bleeding on probing. So you have to walk the probe. Okay, so no need to like just take your probe and you probe one area. You, without taking it out completely from the pocket, you take it out and move it like you're walking, like you're walking with your fingers. Okay, now always also assess the pocket depth and recession and pus discharge. So pus discharge, you take your finger and you press on the sulcus towards the gingival margin, you'll have pus discharge. And also check for presence of periodontal abscesses. Periodontal abscesses, sometimes most of the times periodontal abscesses, the pus will actually come out through the sulcus. Okay, So they may not have much pain or anything, but sometimes what will happen when you have big deposits, calculus deposits and all that, it may block the sinus drainage and block the pus drainage, and it can actually appear as a sinus tract. So don't confuse such conditions with the periapical abscess. Periapical abscess, how to differentiate between a periapical abscess and periodontal abscess is like, first you will have clinical signs, the signs of caries or signs of pulpal involvement, like when you have irreversible pulpitis, you will have such symptoms that won't be present. But again, another easy way to do it is take up if you have a pocket, then it is mostly a periodontal abscess. If you don't have a pocket and if you have a caries, it is mostly a periapical abscess. Or radiographic assessment is another thing. There will be apical periodontitis if there is periapical abscess. It won't be there in a periodontal abscess. Then again, if you also have something called gingival abscess. Gingival abscess is nothing but if when you have small food particles like fish bone or small bones of chicken or meat, or maybe some popcorn shells, or maybe some toothpicks ends, or a brush bristle injury, or some broken off bristles or whatever can actually cause a gingival abscess. Okay, you see this also. Now, what else to check is, there are a few things that you have to see in the dentition. You have to see for open contacts. See, periodontitis mostly is a generalized issue, but if you have a localized periodontitis, mostly there should be some additional features there which would have caused food impaction in that particular area and created a localized periodontal problem. So it can be open contacts, plunger cusps. Plunger cusps are actually cusps of opposing teeth which forcefully plunges between the contact of lower teeth and forcefully pushes or plunges the uh, food particles inside. You can have faulty restorations, faulty cluster restorations, either over contoured restorations or under contoured restorations, marginal leakage. Okay, then you can have proximal or subgingival caries, enamel hyperplasia, especially enamel hyperplasia around the root surface, around the neck of the crown. So many problem with enamel hyperplasia is that area will always be rough and it will be difficult to maintain, and that can lead to gingival inflammation and again root caries and all those things, and anatomical anomalies like I already told. Okay, now another very important thing to check is for occlusal prematurities. See, you can have a periodontal issue. Okay, you can have a periodontal issue. Sorry, you can have a periodontal issue along with an occlusal problem. So what you have to understand is, see, this I'm not going too much into that, but you understand that the centric relation and the maximum intercuspation position should coincide normally. But if you have too much of variation, means if you have an occlusal prematurity, means suppose I'll give you an example. Suppose teeth is missing and the opposing teeth are supra-erupted and it is causing a premature contact with the opposing teeth. What will happen is you may have a shift towards the non-working side. Or suppose you have a tipped upper incisor like class 2 division 2, or a deep bite wherein which your upper and lower anteriors are coming in contact and it is causing a retrusion of the mandible. Anything can be an occlusal prematurity, or a faulty restoration, or a faulty crown, or whatever. Okay, this has to be taken into account. And also see in excursive movements also, means you have simply you have a incisal guidance in which when you protrude, your posteriors, only your edges of lower anteriors along with the upper palatal aspect should touch, and all the posteriors should come in disclusion. And when you have a lateral movement, right lateral, left lateral movement, only your canine should come in contact, and all your other cusps of other contacts of your working and working and non-working cup should be out of occlusion. So imagine when you have, if you have a very, if you have a problem with, suppose your lateral excursion on your right side, okay, and some other contact, some teeth on the working side or non-working side is coming in contact in that excursive moment, that will definitely lead to a periodontal problem in that particular teeth. So typically a very angular bone loss, intra-bony bone loss. Okay, so that also has to be taken into account. This is something that we often overlook. I mean, often underlook. So such things has to be taken into account. And again, another important thing is tooth mobility and trauma from occlusion. See, when you come to tooth mobility, you have to understand the reason of tooth mobility. The teeth can be mobile due to three reasons. This is another important thing which I need you people to understand. Teeth mobility can be due to three reasons. It can be either due to inflammation. You have inflammation, and because of inflammation, you have tooth mobility. This, when you remove the inflammation, this tooth mobility will be completely gone or reduced, at least reduced in the extent. See, another reason for tooth mobility is bone loss. Okay, you can have inflammation along with bone loss. Okay, but whatever it is, when you have bone loss, okay, and the crown root ratio is altered, the bone level is altered, you will have mobility. And don't think that this mobility is going to be reversible. The inflammatory component can be reversed, but whatever already bone loss has occurred can't be reversed. Okay, and the third reason for tooth mobility is trauma from occlusion. See, trauma from occlusion is nothing but the occlusion which is causing trauma. What is occlusion which is causing trauma? Any occlusion which is which is more than a normal, which gives more than a normal biting force. Okay, so again, if you have trauma from occlusion, there can be secondary bone loss. But what you have to understand is this mobility due to trauma from occlusion is also reversible. You have to correct the occlusal problem. Okay, so when you have bone loss, it is not reversible. When you have trauma from occlusion or inflammation, it is reversible. Okay, so this has to be communicated with the patient, and you need to have an understanding about this. Okay, next slide, sir. Now, again, you have to understand, or you have to, during the conversation, the case history taking and the conversation with the patient, these things you have to understand from the patient. See, there are certain risk factors, known risk factors, which will affect the prognosis of your treatment. Okay, so first thing is tobacco smoking. A smoker is always at high risk. So even so, the smoking cessation program should be a part of your treatment. Diabetes, uncontrolled diabetes, the lifestyle modifications and continuous monitoring and medications are required for control of diabetes. And pathogenic bacteria, especially some specific in some specific cases like aggressive periodontitis, you have a lot of specific bacteria like A. commitans associated with that. So that is a risk factor. Okay. Now, anatomic or restorative factors that affect plaque accumulation, that has to be seen in the clinical examination. Presence of calculus is always having a very clear risk when it is concerned with periodontitis. Parafunctional habits. Now about occlusion, this thing I missed. So you always have to ask or look for signs of parafunctional habits like night grinding or clenching. Okay, so see, when you have a periodontal breakdown, an inflammatory periodontal breakdown along with a parafunction habit, that also has to be attended. But what you have to understand is, if when the inflammation is controlled, the tissue will respond better, but still parafunctional habits will deteriorate your treatment result. Now coming to genetics. Genetics is another very important factor. It is not just a risk factor, it is a risk determinant, means you can't change that. The genetics of a patient is something that you can't do anything about it. Again, age or gender or socioeconomic status or stress to stress to an extent is, these are all called risk determinants. These are risk factors which are not modifiable by us. Okay, so genetics. See, genetics, don't think that genetics is only for aggressive periodontitis or severe forms of periodontitis. Okay, genetics is also there for chronic periodontitis. What you have to understand is there are certain genetic modifications associated with the inflammatory process, which actually predisposes the patient to periodontitis, which is again an inflammatory disorder. So you have to take into account that also, the genetics of the patient. You can ask any siblings or your parents have history of tooth loss due to mobility, or are their teeth removed and they have to go for a replacement RPD or implants or FPD in an younger age. So many people, many of our patients won't be aware of this factor. So what about, many times what I have experienced, they will tell no, but they'll go back and they'll talk to their parents and siblings and uncles and all of them. And then next time when they come, they'll tell, okay, my mother had this, my sister had this. Okay. And what is more important is, see, if you are treating an elderly patient, like a 40-year-old or a 50-year-old patient, they may have younger siblings, or they have young kids, or kids who are reaching their puberty. So this thing, if you give them this idea, that will be very helpful, or at least the next generation. Or see, periodontitis, when you treat early, when you understand about the risk factors early, it can be treated in an early stage and you will have a better result. And certain other diseases like HIV, osteoporosis, such things are also um, risk factors. Then another important thing is infrequent dental visits. If a patient is coming to you and if he's coming after 3 years, only when they have a very serious problem. So that is, or the patient has a poor compliance, that is again a risk factor. And previous history of periodontal disease. Sometimes a patient will come to you with all this problem that maybe they would have undergone non-surgical or surgical periodontal therapy before, and always a secondary or refractory periodontal. There is something called refractory periodontitis, which you have to understand. Means periodontitis which is refractory to treatment. So all these things you have to understand from the patient during your conversation or your case history taking. Next slide, sir. Okay, now see, we asked about all this, we found all these problems. Now, this is my experience from a general dentist, from a clinician. Okay, see, you may tell, see, if you see the list of patient's chief complaint, I have written gums are bleeding or swollen as the last point. Okay, so this is the, this is the most important sign of periodontitis or gum diseases. But this is all, most of the times patients last complaint. Some people may come because of gum bleeding. Okay, but many times they do to something about it at home remedies they do, or they don't bother about it. But their usual problems will be something else like this. See, they may come to you for an orthodontic opinion or orthodontic treatment. They will tell, I have spaces between my teeth, or my teeth are proclined, or their teeth must be mobile, maybe mobile, shaky, and they want to fix those loose teeth. Sometimes they come after they lose their teeth, they'll just lose it without any pain, unevenly, or they come to us, okay, they know this tooth is going to lose, so they want to take it out and do a replacement. So sometimes patients will have pain, especially when you have a non draining periodontal abscess. Sometimes what may happen is this periodontal problem which becomes so deep, so that it is secondarily affected, a secondary perioendo lesion, a secondarily infected the root canal, the tooth, the pulp, or sometimes they may even have pain in their gums. Okay, So that may be the problem. Their problem is to they may be bothered about that pain, not about the treatment. Now, many people will come to us complaining of food impaction. They want to manage this food impaction, and some people will come. See, suppose some people will come when their bridges becomes loose, or when their RPDs are not seating properly. Okay, or the abutment, the adjacent teeth of RPD are gone, and now the RPD is loose. They want to fix it. Now, some people will not be bothered about the gum bleeding or anything, but they'll be bothered about the sensitivity, because pain is always a problem, aesthetics is always a problem, appearance is always a problem, not disease. Okay, see, not the signs and symptoms of disease, but the appearance, the aesthetics. Pain is something. Pain, sensitivity. With some people, it may affect their confidence. They will tell, I'm not able to smile. I want to have a better smile. I want to chew better. Okay. Now, what you have to understand is, if you don't treat the patient's chief complaint, you control inflammation, you give all the advice, you give all the treatment, okay, which you feel correct. But if you don't address the patient's chief complaint, you're going to lose the patient. Okay, you're going to lose the patient. See, I'll come to this little later, but since I'm a periodontist and we have to follow certain protocols, see, I will first discuss about the normal treatment protocol, because the understanding of this is important for making a proper treatment plan and executing it. But there are certain variations which is necessary in our clinical practice, which I practice myself, which I will explain in some time. But before that, the scheme of periodontal treatment. So the basic thing is same. The basic understanding is same. Okay. Now, see, this is it. The scheme of periodontal treatment plan. So the initial things are emergency treatment, and when you have some systemic conditions, there are certain precautions that you have to take before starting with the treatment. And now you have the initial phase or the non-surgical phase. So after this non-surgical phase, you reevaluate the patient, and according to the situation, you go to the next phase, which is a corrective phase. This corrective phase has got a surgical phase and a restorative phase. Okay, then again you will have a maintenance phase. Okay, and between the surgical phase and restorative phase also, it's not that everything is done on a single day. You will have this maintenance phase. So maintenance phase comes between every phase. Okay, and maybe phase 2 or the corrective phase won't be needed for any patient, and they'll directly go into the maintenance phase after the non-surgical phase. Okay, fine. Now next slide, sir. Now these are the systemic pre-treatment considerations that you have to say. Sometimes you have to go for antibiotic prophylaxis, what all conditions. Then prevention of bleeding. Sometimes a patient may be taking antiplatelets or other blood, other drugs which can lead to bleeding or delayed clotting. So you have to take into account that, and some other medications has to be changed. Okay, so especially when you have drug-induced gingival enlargement with amlodipine or phenytoin. Okay, so that has to be adjusted or changed. Now, these things has to be taken into account before doing any treatment, and also the emergency treatments has to be taken into account. Now, sir, next slide, sir. Okay. Now, the emergency treatments are a few things. See, suppose if you have a very teeth has to be extracted, the prognosis is very poor. Okay, that has to be extracted before doing a scaling or a non-surgical treatment. We have a periodontal abscess that has to be treated. Patient is having pain due to an abscess, that has to be treated. If the patient has an endodontic involvement, secondary endodontic involvement, or the patient may have a what will happen sometimes is you will have periodontitis, you will have food impaction. Patient will not come to you for the treatment. They will come to you once they will have pain. Why? Because they'll have food impaction and that would have caused a class 2 caries which have involved the pulp, and patient will come for that. So if you tell it is you have to attend that problem first. So extractions, pain, and all those has to be treated first. Okay. Now coming to the next slide. Okay, coming to the phase 1 or non-surgical phase, you also. Okay, now the goal of phase 1, the goal of first phase is to eliminate the etiological factors by means of non-surgical methods. So what eliminate etiological factors means? Plaque and calculus has to be removed. Plaque retentive factors has to be corrected, and major occlusal discrepancies has to be corrected. So the aim of phase 1 is to motivate the patients and to teach them individual forms of oral hygiene. So again, it's not just about the treatment, it is about proper oral hygiene instructions, and oral hygiene modifications has to be advised to the patient, and you have to make them motivated for that. And again, some RCTs are not emergency, that has to be done during phase 1. And you always go for a provisional post-endodontic filling. Provisional doesn't mean a zinc oxide eugenol, a temporary filling, but a GIC filling, which is provisional, which has to be changed later into a direct composite filling or a crown or whatever. But you have to do RCT and of course go for a provisional endodontic filling. Now coming to mobile teeth. Okay. So this mobile teeth has to be splinted. I'll come to that. Now next slide, sir. I think it's more in coming slides. Okay, elimination of plaque retentive factors. See, you have an over contour or a filling or a crown that has to be corrected. That matters the same for under contoured fillings or crowns also, or marginal leakage, and all those defective margins, all those has to be corrected. How can you correct it? You can temporarily you can remove the crown. If you can correct the over contouring by some modification, that's okay. Otherwise, take the crown out, modify the margins, and give a temporary crown for time being. Okay. Or subgingival restoration, faulty restoration is there. You can remove the restoration and do a GIC filling or something for time being, which has to be a more permanent restoration has to be given later, but all these things can be done. Okay. Now provisional treatment of carious lesions, and if you have endodontic involvement, that has to be done. And anatomical deficiencies like all these things I told. I mean, cervical enamel pearls or enamel projections or deep concavities, root proximities, all those things can be corrected. Now, another thing is closure of open contact points. When you have constant food impaction and all those things, that will lead to, so you have to correct that contact points. Then if there is a frenum or insufficient vestibular depth, doesn't allow the patient to maintain a proper oral hygiene, that has to be corrected. Malposition teeth can be corrected with orthodontic treatment. Crowding and rotations and all can be corrected by orthodontic treatment, but make sure that there is no active periodontal disease at that time. And this thing, hypermobile teeth with a poor prognosis. Okay. Or there can be mobile teeth which can be maintained. See, both this, even if it has to be extracted, or a mobile which has not been extracted, will lead to inadequate oral hygiene maintenance. So what you have to do is you have to do splinting for that. Okay, you have to do splinting for that. Don't, if you tell a patient, see, whatever I am marked in red is very important. This is all different concepts which I do. Okay, so what I do is, when you get a patient, okay, patient is coming to you, he'll have all mobile lower anteriors. Maybe one teeth is symptomatic or grade 3 mobile. There is a periodontal abscess there, or patient comes with the teeth. I mean, the teeth is actually gone and he's coming with the teeth in his hand. So what you will do? So when you see such a patient, the ideal if you tell, okay, all these teeth has to be extracted, then you have to do periodontal treatment, then we have to wait, and then we will go for a permanent this thing. You lose the patient. Patient's problem is not his signs and symptoms of periodontitis or perio problem. His problem is he wants to make the teeth, the shaky teeth has to be corrected, the aesthetic concerns and all that. So what I do, see, very, very, very important part of my clinical practice is splinting. The material of my choice is something called super bond. So what you have to understand is splinting. I'll come to that later with clinical photos, but what you have to understand is the splinting is very important. And I told you, if a teeth has to be extracted, what ideally you can extract that teeth, wait and do something. But what I do is I extract that teeth and I reattach it. I'll splint it along with the mobile teeth. This is called a direct bonded bridging. I'll come to that how I do it. But this is a very treatment management, because patient, if you extract and if you do perio management, and if you talk a lot about perio management and oral hygiene and all that, and if you blame the patient for this and this, you reach the situation, then the patient is gone. But what you have to give them is, what I do is I do a deep scaling along with splinting of all mobile teeth. If some teeth is already lost, if the patient is having the teeth, I will attach it, reattach it. Or the teeth is gone, I'll take an acrylic teeth, I'll make a composite teeth, and I will splint it along with splinting of all other mobile teeth. And this has drastically changed my clinical practice. So this is one thing I want all of you to follow. This will really retain your perio patients. See, what you have to understand is, when you lose a perio patient, see, suppose a perio patient is coming to you and you are advising a surgical treatment. Flap surgery, you are telling. Patient will run and go. The patient will not come back. So what you lose is not just the flap surgery, but all the other treatment, all the other, maybe restorative management or aesthetic management, prosthetic management, implants, all in that patient. And again, what you have to understand is that patient is gone. He's not going to refer any other patient to you. So you lose all other patients which that patient may bring. Then again, the family members of the patient. Okay, so never ever communicate the ideal treatment plan to the patient and lose that patient, but you improvise. You always give a solution for the chief complaint. Okay, now why the splinting is important? It supports adequate oral hygiene. Always firm teeth will be more easy to clean. Okay, and it promotes stable occlusion. It promotes equal distribution of masticatory forces. Okay, and if you do a surgical or non-surgical phase, a blood clot will be formed around the root surface, and this splinting helps in stabilization of the clot. Okay, the next slide, sir. So splinting forms a very, very important part of non-surgical phase. Now, mechanical removal of dental plaque and calculus. So supragingival and subgingival scaling. This is the only thing that I do. Supragingival and subgingival scaling. I don't do root planing. I don't do cure attach. And I do the supra and subgingival scaling with what? With ultrasonic instruments. With a common scaler, piezoelectric scaler that all of us have in our dental setup. So the only instrument that you need to do perio treatment is a scaler. Surgical instruments are different, but to manage a patient efficiently in your dental practice, the only instrument that you need a scaler and the thin sharp tip of the scaler. Okay, and the interdental tip of the scaler. Okay, now see, when you are doing scaling, see, scaling is something which is very much underrated. So, and many people are scared. Many dentists are scared about scaling, and many patients are also scared about scaling. That may be due to their prior experiences, maybe due to peer influences. Okay, or sometimes even some dentists would have told them don't scale more, and you will start losing your enamel, or all this negative comments they would have maybe got from a dentist also. So what you have to do is, see, when you're doing ultrasonic scaling, there are three things that you have to keep in mind. Okay, and believe me, I do all the subgingival scalings without giving LA. Without giving LA. Okay, so what you have to do is, you keep the power setting within 1/4 or maximum 1/3. Maybe if you have 10, a power setting of 1 to 10, you keep it below 4 or keep it below 3. Okay, means within 1/3 or 1/4 of your total power. Always keep this in mind. Second thing, the water, the water spray, you keep it at the maximum. Maximum water spray, minimum power. Okay, and third thing, don't overuse your tips. See, what you have to understand is, along with all scalers, you have something called a tip card. What you have to understand is the apical 4 millimeters or the 2 millimeters, the mostly the 2 millimeters, but the apical 4 millimeters. From the tip, if you measure the 4 millimeters, more important, the 2 millimeters are actually the active part of the tip. And again, not the tip, the sharp tip. You should never touch the teeth with the sharp tip, but either with the edges, the 4 millimeters or 2 millimeters of the edges. So what you have to, what is a common problem with all of us is, see, what we do, we take this thing when we keep on using in high power. Okay, so you want to finish the procedure first, you use it in high power, and the assistant won't be ready to change the bottle frequently. So what they will do, they'll purposefully keep the water spray in the minimum, so the booster bottle will not get discharged very easily. Okay, so you tend to, there will be a lot of heat generated, a lot of scratches, mechanical this thing happening. So what will happen eventually is your tip will also get damaged. See, you have to periodically change it. You check it with the tip card. What I suggest all of you is, today itself, when tomorrow you go to your clinics, along with all the scalar systems, you will have a tip card. Take your tips and measure the length of the tip. The active part is only 4 millimeter. Already 2 millimeter, and the most important part is the apical 2 millimeters. That must have been worn off. That is why your scalers are not efficient. And another thing which you have to understand is, when you do the scaling, you should have a modified pen grasp, and you should handle the instruments very gently. Okay, so whenever you have, see, these instruments work on the principle of ultrasonic scaling. You won't be able to see with your eyes the vibration, but there are continuous oscillations happening there. So for these oscillations to happen, this instrument should be held passive. Okay, so when you apply a lot of pressure with your hand, what happens is, these oscillations won't be happening, and there won't be any mechanical advantage there. So you have to handle these instruments very gently, periodically change the tips, keep a low power setting within 1/3 to 1/4 of your maximum power setting, and keep the water flow to the highest maximum water flow. I assure you, take it from me, I'll write and sign it for you, all of you. If you follow this, scaling uh, will be tension free. Patients, it will be pain free for them. They won't be having sensitivity, they won't be having any problem. But believe me, all the problems with scaling happens when you don't follow such protocols. That is why I told, scaling is the least taught, ultrasonic scaling is the least taught concept. Okay, or what we practice. If you normally follow this scaling, you'll get patients only for scaling. You'll get a lot of revenue from scaling if I want to be very honest. Okay, and patients will routinely come back to you for scaling. Okay, so okay. Now coming to air abrasion systems, there are air abrasion systems which you can use, but the very good one will be okay. Leave it, like we'll move to the next slide. So okay, now I think we are already running late, so I will just okay. See now these are other practical things which you can do. These are other practical things which you can do. Okay, on a full mouth disinfection. See, other than see, this is about how you can manage efficiently a patient in your clinical setup without calling up specialist. By things and by armamentarium which you have with you. So the concept of full mouth disinfection you have to understand. You do full mouth scaling and root planing. This root planing I mentioned already. It is not practiced nowadays. Within 24 hours. No need for within 22 hours. You can finish the scaling in one sitting. Maybe it will take 1 hour or maybe it will take 2 hours. A thorough scaling will, full mouth subgingival scaling will take to maybe 2 hours. Okay, so you can okay, fine. Now along, so there should be pre-procedural rinse with 2%, 0.2% chlorhexidine, and after instrumentation all the pockets has to be rinsed with 1% chlorhexidine. It's nothing, something like we irrigate our root canals. You take a 10 cc syringe, fill it with chlorhexidine, chlorhexidine. You can even use the dilute and use the chlorhexidine you use for root canal irrigations. So rinse the pockets after instrumentation. All the pockets should be rinsed with chlorhexidine. Then also with 1% chlorhexidine gel, you can scrub the tongue. Tongue scraping can be done. All these things you do in the operatory, and then you advise the patient to use chlorhexidine mouthwash twice daily, 0.2% chlorhexidine mouthwash without dilution twice daily for 2 months to prevent reinfection. Okay. Now, now how to use mouthwash? How to use mouthwash? The way I recommend patients to use mouthwashes, I tell them to use it at least at night. Twice daily is sometimes difficult. I'll tell you why. See, the easiest, the best way to use mouthwashes before going to bed, you take 0.2% chlorhexidine mouthwash. I'll tell them how much quantity you can take in your mouth, 5 ml or 10 ml. You take without dilution. You gargle for 30 seconds to 1 minute, and you spit it out. After that, don't wash your mouth. Don't consume water. Go to sleep. This is something which you do immediately before sleeping. Okay, and also the brushing has to be done half an hour before that. So what I will tell them is, you have dinner, you wait for half an hour and brush. See, another important thing about this thing is brushing. See, especially this perio patients will have a problem of food getting stuck between the teeth. So they tend to uh, um, brush immediately after every meal. But this is the main reason for sensitivity, for root surface dissolution. So what you understand is maximum acid activity is happening immediately after consumption of food or beverages also, for that matter. Tea. Many people have that habit of having a morning tea, a bed coffee or a bed tea, and then immediately going and brushing. Okay, that also causes sensitivity. Okay, or this okay, so this is important. So after having dinner, wait for half an hour, brush, wait for another half an hour, or till the time you're going to sleep. Before going to sleep, mouthwash without dilution, no washing, rinsing, drinking water, directly go to sleep. Okay, night time. Okay, now they can use this mouthwash once more in the daytime, maybe around 11 o'clock between your breakfast and lunch. But this will be difficult for working or students, working people or students, because it will be difficult for them. That's why night brushing is very important. And when you brush in the morning time also, you have to wait for half an hour after food. After this also, you have to wait for half an hour before drinking water or rinsing and all that. Okay. And most of the times, you believe me, the staining occurs, staining of mouthwash, this thing occurs, especially because after using mouthwash, they take some beverages, especially coffee or cool drinks or anything. Okay, and that tends to get adhered to the tooth surface, so that has to be avoided. And believe me, see, if you use this chlorhexidine, this thing, there are problems of staining and all that, but that is a later issue. First, you have to manage the disease, and chlorhexidine, 0.2% chlorhexidine mouthwash is the best for that. Now, there are certain other things which I do in my clinical practice. There is something called photodynamic therapy. How I do photodynamic therapy is, there's something called Periogreen, which I use with my diode laser, which is Elixion. But Periogreen is not available currently. I'm not fully aware of that. This photodynamic therapy is nothing but you're injecting, you're just introducing some dyes into the pocket, so that the periodontal pathogens will absorb that, and that will become highly sensitized to the either the laser light, or there are certain other particular specific light sources for that. Now you understand, you do mechanical debridement and all that, but there are certain bacteria which may not be removed by all these procedures, but by using photodynamic therapy, such bacteria can be dealt with. But this periogreen is very costly. So I don't know. Please enlighten me if some of the products are available. I'm not aware. Now, another thing is low-level laser therapy. Low-level laser therapy is with diode laser. If anybody is having a diode laser, this is something that all of you can do. Low-level laser therapy, non-cutting mode, you can introduce it into the pocket. Okay, this has got very definite advantages for disinfection of biofilm. Okay, soft tissue disinfection and all that. Okay, but again, I told the core aspect of periodontal management is root surface debridement. If you remove the root surface deposits, other inflammatory factors will reduce on its own. But definitely, when you're trying to treat the patient with the non-surgical management, it is also about patient comfort. Your patient is coming, you're doing a proper, very comfortable subgingival scaling. Along with that, if you're coupling it with a low-level laser therapy, that gives a very good impression to the patient. You can charge, definitely you can charge. Okay, and there is something called a LANAP, laser-assisted new attachment procedure, which has to be done with the hard tissue laser. I'm yet to do that procedure. So, okay, that is again a wonderful procedure. There are a few doctors in Kerala who are doing that. Now, next, yeah. So this is again about laser, which I told. I'm skipping this slide. Next slide. Next slide, sir. Okay, now a word about pharmacotherapy. Okay, see, these all things are there. So you can use antiseptics and antibiotics, direct microbial action. Okay, there is the early hypothesis of our this thing of periodontitis or gingival lesion was about non-specific plaque hypothesis. Then it became specific plaque hypothesis, means specific bacteria present in the plaque actually causes periodontal destruction. Okay, so you target your antimicrobials towards this specific bacteria. Now the concept is again changed to host response. It is not just the bacterial action, it is the host response, the host bacterial interaction, or periomedicine. Okay, so you can also do something about this inflammatory pathways. Okay, but we'll talk only about proven things. or which are available in India. So what you do, you manage with antiseptics and antibiotics. Antiseptics, I already told the best antiseptic is 0.2% chlorhexidine mouthwash. We'll also talk about this thing about anti-infective therapy. See, always the gold standard of periotherapy or something that I follow is, see, believe me, everything what I told is what I follow in my clinical practice. Okay, a combination drug, combination therapy. Either I give a combination of metronidazole and amoxicillin. My favorite combination is 400 milligram metronidazole. Flagyl or metrogel 400 milligram thrice daily for 5 days in combination with 500 milligram capsule amoxicillin thrice daily for 5 days. Thrice daily metronidazole and amoxicillin for 5 days in combination. Or if you feel if you have a better confidence with amoxicillin, potassium clavulinate, you can go for amoxiclav or augmentin along with metronidazole. This amoxicillin plus potassium clavulinate, you can either give, you can give 625 milligram twice daily or thrice daily. There are different practitioners which follow different modes. Now, a patient which is allergic to amoxicillin or penicillin allergy, you can go for ciprofloxacin along with metronidazole, ciprofloxacin or ofloxacin. The advantage is you have a single tablets for this. Metronidazole and amoxicillin is a single tablet is not. Somebody has come up with something in the market, but I don't prefer that. Always, patient has to take one capsule and one tablet thrice daily for 5 days. So instead of that, you can go for a combination of ofloxacin and ornidazole. There is a mistake in the script. It is ciprofloxacin or ofloxacin. Okay, so this is another, and that 500 milligram is also wrong. Sorry for that. Okay, so you can go for a combination of ofloxacin and ornidazole. Okay, so this I already told, 0.2% chlorhexidine mouthwash twice daily without dilution before bedtime and morning half an hour before or after brushing and consumption of foods or beverages. I already explained it very clearly. Now, something which we very commonly use in our clinical practice is metronidazole gel, metrogel, or ornidazole gel, ornigel. Okay, or you can there are also chlorhexidine gel formulations like hexigel and all that. Okay, but what you have to understand is this metronidazole, imidazole group of drugs are active against anaerobes. Okay, only active against anaerobes. So where are the anaerobes present? It is present in the deep pocket, not even at the superficial pocket, the depth of the pocket. So I don't know how much useful is this, but what you can understand is if the patient can somehow introduce these oral gels or even chlorhexidine gel subgingivally. So there are few doctors who tell the patients to actually push it into the sulcus, especially in the initial inflammatory stage. They can push it into the sulcus with maybe a any interdental brush or maybe a toothpick, or I don't personally prefer this, but if these such drugs has to be effective, it has to act subgingivally, or it has to reach the deep pocket, or maybe people also tell like somehow it will reach because it's in the mouth. Okay, anyway, so that is about it, and that is about topical application of antiseptic gels or antibiotic gels. Then you have a very commonly available Ayurvedic medication, antipyol, and I also have one of Himalaya product called Hyora SG gel. Okay, all these things are very patient comfortable. I find patients liking and asking again for such medication. So I just wanted to mention it. Okay. Now, what about next slide, sir? Okay, now about occlusal therapy. What is important is how to achieve those occlusal corrections. You have 3 ways to do it. You can either remove hard tissues, means selective coronoplasty. This is especially important when you have a occlusal interference in your excursive movements or maximum intercuspation or the movement from centric, and there is a lot of alteration from centric and maximum intercuspation due to an occlusal interference. You can selectively mark that area and you can grind that, but you have to follow the principles of occlusion. You can read Dawson or any textbook for that. And then this is the same for all prosthetics and everything. Now, coming to another, this thing is additive procedures, restorative buildup. Okay, sometimes you have to do some addition treatments, additive treatments. Okay, you can have something I find very useful is something called bone fill. This is especially I do this for parafunction cases when you have to raise the bite. Bone fill is another material which I find it very easy to do it. Okay, or you can do with direct composite restorations or indirect composite restorations or indirect Emax restorations. Okay, so I always prefer an overlay or an occlusal veneer for occlusal corrections other than a full crown or something of that sort. Okay, and you also can have orthodontic treatment. Okay, when you have a teeth or you have a rotated teeth or if you have a steep teeth or something, you can orthodontically correct it. Make sure that there is no active periodontal disease at that time. Okay, so these are all roles of general dentist. You see, this the perio patient is like a gold mine. If I tell you, I should not tell this. Okay, don't think that it is it is from a monetary point of view. But you imagine a perio patient is like a gold mine. Okay, you just have see many times I go as a consultant, as a perio consultant. I know the clinicians. Many I know now many people are listening to this thing. So you yourself know how many of you actually call a periodontal specialist. Okay, periodontal specialist or a periodontal specialist coming and after that something is happening and how to continuously manage the patient or what is the benefit of the clinic. Okay, so imagine so understand that a periodontal patient is like a gold mine. You get to do a lot of things. You go to do lot of restorative treatments. You get to do a lot of permanent prosthetic management. You get to do implants. You get to do aesthetic and cosmetic procedures. You get to do desensitization managements. You get to do occlusal corrections, full mouth rehabs. Okay, but just imagine you lose all that by a wrong communication to the patient. You come to the patient, you tell them, okay, there are two common mistakes that you make. Either you blame the patient, your oral hygiene is poor and there are no options and all that. Or what you will do, you will directly give them a surgical option. You will tell them about surgery. Patient will run away. And another, there is from other than from the monetary point of view and from all of us are clinicians and we at the end of the day we make money out of our patients and we make a livelihood out of it. But there is another aspect to this. See, imagine the periodontal burden which is presently there in the society, in our society. Okay, a patient, there is a lot of periodontal burden. There are a lot of patients who are ignorant or who are not ready to do periodontal management. And believe me, periodontal burden is the most serious systemic cause. See, see, I'm talking about oral conditions. You have dental caries, you have sensitive, a lot of other dental problems, but the dental problem which can cause maximum systemic burden is periodontals, the chronic inflammatory condition like periodontitis. Just got non-relation with your cardiovascular problems, diabetic glycemic control, low birth in ladies, low birth weight issues, preterm deliveries, lot of things. And again, what you have to understand is something a patient who is not ready to undergo periodontal treatment under you is not going to go anywhere else and do periodontal treatment. Okay, he'll not. Okay, and sometimes what many dentists tend to do is I've seen many cases where in which they manage it by doing full mouth RCTs and giving full crowns, and that to join crowns. I seriously don't know uh, idea, what is the logic behind that. Okay, a periodontal management done by endodontic and prosthetic this thing. I don't know what is the idea behind that, but so this is how it should be done ideally. Okay, now, okay, is this a slide? Reevaluation. Now the first phase or the non-surgical phase is over. This is the most important phase. Okay, now you have to reevaluate after this phase. Okay, uh, so you have to wait for 6 to 8 weeks to measure the periodontal parameters. Okay, otherwise if you do a probing before this, you'll actually delay the healing. You will actually hamper the healing. Okay, I'm not going deep into the healing mechanism of non-surgical or surgical periodontal treatment, but what you have to understand is, if you probe up this thing, okay, for probe up, if you probe within 6 to 8 weeks, okay, that will actually going to affect your system. Okay, now if the inflammation could not be reversed, okay, and the patient is not able, and or if due to some reason, the patient is not able to provide himself, or we are not to provide them a proper oral hygiene, okay, then the patient has to go to the next phase, corrective phase. Okay, see, the second point is like, it is not possible to provide individual and professional oral hygiene means, if the patient is having a high frenal attachment or a compromised vestibular depth, or some anatomical or some other problem which requires a surgical or corrective treatment in order to better okay, better maintain. Okay, so that is a good. Then what you have to understand is, the patient motivation and cooperation is a prerequisite for this phase. So what you can do is, if you feel like the patient the recorded parameters are not acceptable, then what you can do is, you can repeat the phase one, repeat the non-surgical scaling, or what you can do is, then again, if it is still not successful, then I will really tell you, never go to surgery. Just stick on to palliative treatment, and whatever temporary restorative management, or whatever restorative management which is necessary, you do it. Okay, next slide. Now coming to the corrective phase, or the phase two, which has the surgical phase and the restorative phase. See, what you have to do, what you have to understand is, a surgery phase, there can either be repair or regeneration with surgery. 90% of the times it is repair, and believe me, and that is enough. Okay, so only when you have a defect, which you can do some bone grafting, or some collagen member, some GTR, and do regeneration. These are only very few of the bone site, very few of the sites. But 90% of sites, or 90% of the patients, what you mean by surgery is an open flap debridement. I told you, the root surface debridement is the key of periodontal management. If you can do it non-surgically, good. If you can't do it non-surgically, you raise a flap, and after clinically seeing it directly, you do root surface debridement. It is called open flap debridement, and you will get a repair. The desirable end result will be repair of the periodontium. Means the disease-free pocket, or the disease-free soft tissue, and the disease-free hard tissue, means the cementum and the sulcus lining, will have a very tight, close adherence. We call this long junction epithelial attachment. Okay, this is the most desirable, or the most common outcome out of a periodontal surgery, be it a surgical management or non-surgical management. The difference is, we can achieve it non-surgically, well and good. If you can't achieve it non-surgically, open a flap, clinically see it, and do it. And regeneration is only available in 10% of the cases where you can actually do a bone grafting. Okay. Now, another thing in corrective phase is periodontal plastic surgery. There are a lot of different, I'll come to that. Now, we talked about temporary splinting and all that. Now, occlusal therapy, long-term stabilization of the teeth. Okay, there are other things there, we will come to that. Then orthodontic therapy and restorative therapy. Okay, so restorative therapy, direct or indirect restorations, prosthetic treatments, and insertion of dental implants. These are more important from a general practice point of view, more than just doing the perio part. Okay, the corrective phase, especially the orthodontic, restorative, prosthetic, occlusal, and other aesthetic treatments which you have to do to a periodontal patient, which will be done by the clinician of that particular clinic. Okay, now coming to the next slide. This is again that surgical phase. I'm not going too much into the, all of you know what is open flap debridement. Okay, so you have to do a pre-procedural rinse. Then after anesthesia, flap incision. The flap design is very simple. Flap design is very simple. The only thing which you need is a number 15 BP blade and a BP handle, whichever is your convenience. Okay, a flat one or a round one or an angulated one, whichever according to your convenience. Take a 15 number BP blade. From the distalmost teeth, go towards the mesialmost teeth. Okay, just put a crevicular incision. Take a BP blade, start from the distalmost teeth and move around the teeth, around the neck of the teeth by hitting the bone. Make a crevicular incision. Okay, that is the only instrument that you have to use to make an incision. Now take a good periosteal elevator and elevate the bone below the level of bone destruction. Okay, at least 1 to 2 millimeters of bone margin below the level of bone destruction has to be raised. Now, most of the people what they encounter is they don't trace a good flap. See, a good flap should include the periosteum, whether it is for a impaction, whether it is for an extraction, whether it is for an implant, whether it is for a plastic surgery, whatever. Most important thing is trace a full thickness flap with the periosteum. Okay, with the periosteum. And now debridement of granulation tissue. See, I told you the core aspect is root surface debridement, but you should be able to see the root surface till the defect, the apical extent of the defect very clearly. For that, whatever granulation tissue which is actually hindering your visibility should be removed. I do it with a laser. You can do it with a curette. Okay. Then you will have interdental granulation tissues, which is very easy to use a curved scissors. For that. Okay. Castroviejo scissors or whatever. Okay, it's very easy to remove the interdental granulation tissue with a scissor. Now, all the granulation tissue are removed with a laser or with a scissor or with a curette or even with a scaler. Yeah? Okay. Now, you have to remove the root surface. That is removal deposits on the root surface and root planing. This root planing we no longer do, at least I no longer do. Okay, that is another reason for this postoperative hypersensitivity. Okay, now I don't do root planing, but the removal of deposits on the root surface. And this is very important. You have to, once you are opening a flap, to 100%, you have to remove the root surface deposits. Okay. From 360 degree, you have to remove the root surface deposits. Now, there are two more things, resective and regenerative procedures. So if you have a bony defect, like if you have a reverse architecture, if you have an interdental crater or something, okay, see, just think that to have an understanding about resective procedure, after you open a flap and you do a degranulation and debridement. Now, if you think any if there are any bone defects which will hinder the patient in proper management, like you have a spicule of bone and you have an inaccessible area. It is better to just make that area self-cleansable by doing osteoplasty, that is osteotomy. Okay, or a regenerative process. Okay, you actually do biomodification of root surface with citric acid or something. I don't do it, but that is one thing. Only thing important is the root surface will be clean of all the root surface deposits. Now you can use any regenerative material like bone grafting. Sometimes you have to cover it with a collagen membrane. Okay. Now in both, sometimes it can only be open. It may be only open flap debridement. Sometimes receptive procedures are required. Sometimes regenerative procedures are required. Whatever after that, you close the flap and put a suture. I don't give periodontal packs. No periodontal packs at all. Something which I hate, which I don't give any time. I have my own reasons for that. Now just close the flap. I usually follow a continuous sling, indirect. I always follow a continuous sling suturing for this thing. Means I'll start from the distalmost teeth. I'll come buccally, then I'll pass lingually through the teeth above. Then it's okay. This I don't think it. I can explain it without a actual demonstration. Okay, now the next slide is periodontal plastic surgery. Okay, now a little word about periodontal plastic surgery. See, what are the conditions in which you have to do periodontal plastic surgery? Means there's a condition in which you have inadequate keratinized gingiva. Okay, means there is too much of recession, or certain areas of the teeth will have, especially the lower premolar area, will have less of keratinized gingiva. And if you have a thin biotype, this will lead to recession. What will happen is the gingiva will be very weak to toothbrushing. The patient will be having pain or having soreness when they brush. Okay, or they'll have recession when they brush properly. This will affect their maintenance. So you can augment inadequate keratinized gingival width or a thin biotype. Okay, you can augment it with a connective tissue graft or a gingival graft or a repositioning flap. Or there are a lot of ways to do it. Okay, but I just want you to know sometimes periodontal plastic surgery is a part of the corrective phase, which is absolutely necessary for the patient to have a proper periodontal maintenance. Now, abnormal frenum, you have a high attached frenum, which is affecting the toothbrushing or which is causing gingival recession. And you have insufficient vestibular depth, especially lower mandibular anterior labial sulcus. Okay, you have a high attached frenum and a decreased vestibular depth. The patient won't be able to maintain that area properly. You have to do a vestibuloplasty. You can do all this procedure with laser. I do it with laser. You can do it with a normal scalpel or whichever way which it is easy. Now, recession due to toothbrush trauma, mainly due to aesthetic reasons, that can be corrected by a repositioning flap or a connective tissue or a free gingival graft. Sometimes people will have gingival excess either due to medication or due to altered passive eruption or due to vertical maxillary excess. Okay, and you need to have a diagnosis for that. So when you have a gingival excess, you first need to have a diagnosis for that. You need to know, maybe it is a skeletal issue. Maybe there is a vertical maxillary excess. Okay, maybe there is a very short anatomical upper lip. Sometimes anatomical upper lip will be, anatomically it will not be short, but you will have hypermobility. When the patient smiles, it will be hypermobile and there will be too much of gingival display. It can be eruption problems. It can be altered active or passive eruption. So depending on whether it is altered active or altered passive eruption, you have to think about osteoplasty also. This is altogether a different session, but I just want to touch few points. Okay, fine. Now asymmetric gums, especially after orthodontic treatment or maybe due to recession or something, asymmetrical gums, which may lead to aesthetic problem. Then insufficient crown height, which requires crown lengthening, subgingival tooth margins. Okay, All these may require a crown lengthening, either with osteoplasty, without osteoplasty. Okay, and again, there may be deficient soft tissue or hard tissue on edentulous ridges, missing teeth area, either FPD, the pontic of an FPD, or an implant. You'll have deficient soft tissue, hard tissue, and edentulous ridges. All this can be corrected by periodontal plastic surgeries. Next slide. Sir. Okay, few of the examples I told about inadequate keratinase, gingiva, and uh, again thin biotype. So you can imagine such a situation is there. It will be very difficult for the patient to maintain. This absolutely requires you can either go for a lateral pedicle double papilla graft, or you can go for a connective tissue. Maybe lateral advancement flap has to be augmented with a connective tissue graft later. Okay, then on the other side, you can see a high frenal attachment. Frenectomy is done. Okay, or you have gum recession due to faulty toothbrushing. So understand first the hard tissue has to be corrected. Now, another role of periodontist, which I feel, see, when I go for a consultation, I don't just stick on the perio, but I do a lot of biomimetic restorations. See, imagine in this situation, like cervical abrasion is there. It will be very difficult to properly do a restoration without doing a marginal, without having a marginal issue here. So you need to do it under rubber dam with proper gingival retraction. You can use gingival retraction clamps, or you can use retraction cords, or but whichever way, the restoration should not affect the margin. Okay, and after that, the soft tissue correction can be done by the same methods which I mentioned. Now the next slide, sir. Next slide, sir. Now a word about management of dentine hypersensitivity. This also becomes important many times. Many people have many dentists also, or many patients have a fear. What if they have sensitivity after doing scaling or after doing a surgical management, periodontal management? Okay, so what you have to understand is one thing I told about toothbrushing. See, don't see, even as I told about food impaction, people tend to brush immediately after having meals. Same thing with hypersensitivity. They tend to brush every time after meal, and that too with hard brush, long time of brushing, and especially when you have a thin biotype, when you have roots exposed. Okay, hard toothbrushing leads to sensitivity. So that habit has to be corrected. And a removal of other risk factors by educating the patient about dietary acids and other oral care habits, like you have acidic food and beverages like citric, lime soda, and a lot of, and this what do you call, I mean, this aerated drinks like Coca-Cola, Pepsi, and all that. And having snacks along with, sometimes even I have that habit. I had that habit of me. Whenever we have a chance, we go out, just get us lime soda and a puffs or something. So all these habits will actually lead to hypersensitivity. Swimmers, there are a lot of other reasons also. Okay, so that has to be taken into account. Desensitizing agent for home use. See, sensitivity, you have to identify the exact reason and accordingly suggest a desensitizing toothpaste. Okay, suppose a patient is having acute hypersensitivity, you should always go for some a paste which has an active ingredient which has something to do with the nerves, like potassium nitrate. Okay, this Shy XT, or any brand for that matter. Okay, so but one thing that you have to understand is when you are giving such nerve altering hypersensitive toothpaste, it has to be used for a short duration, not more than 3 weeks to a month. Okay. Once that acute hypersensitivity is managed, you have to change it into any other toothpaste which actually acts by occluding the exposed dentinal tubules. That is another mechanism, or the commonest mechanism of desensitizing toothpaste. Okay. Now, another thing which you have to take into account is, does the patient only have hypersensitivity, or the patient is having enamel hyperplasias or high caries risk and all that. Okay. Such conditions require some other this thing which has got a remineralizing and desensitizing action, like a claim or else or enough fix or something like that. Okay. Now, okay, and again, when they use this desensitizing toothpaste and they start getting relief, they should not overuse it, should not overbrush. Okay. So what will happen many times is patient will get a relief and they'll tend to do it more. That will actually have a deleterious effect. Okay. Now you can also have in-house or in-office desensitization. Okay. Something I use very common is MS cotton. There are a lot of different clinician preferred different topical desensitizing agents which you can choose. Okay. Now laser desensitization. I find it useful for some patients. Okay. Again, that is another low level mode of laser, of diode laser, which you can use for laser desensitization. Next slide, sir. Now, coming to the maintenance phase. Okay, regular checkups are needed to be done, and some treatments are performed if necessary. Okay. Now, the frequency of checkups varies depending on the patient's motivation, the nature of the disease, whether it is an aggressive form of disease or a chronic form of disease, and presence of etiologic factors. Means modifiable or non-modifiable etiological factors are present, like genetical predisposition, smoking, diabetes, and other systemic conditions. The patient is old and not able to maintain properly. Okay, all these things. Then against okay, all these things have to be taken into account when you decide on the maintenance phase. Next slide, sir. This is important. This is little boring, but this is very important actually. Okay. So professional measures can reduce bacterial load and influence the composition of the plaque that reduces its pathogenic effect. Means always long-standing plaque, matured plaque is more pathogenic. So when you have periodic cleaning, okay, and one more thing you have to understand is it is mostly aerobes and super aerobes or gingivitis causing periodontal pathogens, which is initially seen, but the late colonizers are actually anaerobes. So you do continuous deplaquing without maturing the plaque. So you have a better prognosis. Okay. And even the bacterial load can be reduced. Okay. Now, when you have regular maintenance visits, regular recalls, the patient's motivation and instructions are increased. See, instead of every time if you tell them the oral hygiene instructions and toothbrushing techniques and use of interdental aids, they tend to understand it better and have maintained it better. Okay. Now, another important thing is you can diagnose early. When some other periodontal issues are coming, you can diagnose it in an early stage, like a pocket formation. Suppose some area is difficult to maintain, and a pocket is seen, or something is seen. You can do something. Even a therapeutic procedure can be done in an early stage. Now, another thing is the adverse effects related to therapy can be prevented. That I'll come to in a later stage, the later slide. Now, next slide, sir. Next slide. Now the risk analysis. Okay, there is something called something introduced by Lang and Tonetti called bone spider. This is actually, it assesses 6 factors. So they assess the gingival condition. They actually probe and check for the bleeding. And the number and ratio of residual pockets they will check. Ratio of missing dentition. Attachment level, it should be in relation to age. If suppose a patient of young age is having more of attachment loss, that is considered more having a bad prognosis. Then other medical conditions like diabetes mellitus and smoking. So based on these, okay, now next slide, sir. So based on this, the patients will be categorized as low, medium, and high risk patients, and accordingly you will decide their recall visits. Okay, so this is one chart they follow. Now next slide, sir. So now this is the take. This is what you have to understand. Now, how will you schedule the recalls? So in aggressive forms, okay. So every 3 to 4 months you have to recall them. Slow progressive chronic diseases you have to recall them every 6 months. And in highly motivated and periodontally stable patients, you only have to recall them once in a year. But again, on the other hand, in high risk patients who cannot reach the required plaque scores, now they have to be, the recall has to be increased to 2 months, never earlier than that. Now, less than 2 months recalls, I told you 6 to 8 weeks before that, if you actually do a periodontal screening, that will actually worsen the periodontal parameters. So the periodontal tissues would not get a chance to regenerate. So any high risk patient, a recall and assessment of periodontal parameters within 2 months is not indicated. Now next slide. Now when you have a prophylactic visit, this is 1 hour. See, this is actually in the Western population where the dental hygienists do it. Okay. Now this is divided into examination, reevaluation, the checking of periodontal parameters and recording it. Now instrumentation. Instrumentation means this non-surgical management, this subgingival scaling, supra and subgingival scaling. Okay. Now coming to treatment of active pockets. Okay, that is one thing about maintenance visits. You have an active pocket, you will be able to identify it early. Okay, now treatment of active pockets. Now, if you have a senior dentist, suppose in your clinic, a junior dentist or a hygienist is available and they will be doing the routine maintenance visits, the senior dentist can go and evaluate. Okay, or a periodontist, if is available, can go and evaluate. Or you can put another appointment for that evaluation. Okay, so now this is a prophylactic hour introduced by Wolf and Ritzky. Now, next slide, sir. Now, I told you when you have routine maintenance visits, you will be able to deal with the adverse effects of maintenance therapy. What are the adverse effects? There can be hard tissue loss on the roots. Okay, when you have more of tooth loss, you'll have more of sensitivity, and it will make the patient more difficult to maintain because they'll not be able to touch or clean it properly. Okay, and root caries. Root caries. See, what you have to understand is, okay, root caries and tooth sensitivity. But if you just follow non-surgical the scaling with subgingival scaling by just doing root surface debridement, the proper setting, which I already mentioned, and if you avoid SRP, if you identify the recession, if you direct the patient correctly towards oral hygiene measures, which will not cause root surface damage or gingival recession and hypersensitivity, you'll be able to manage this. Now, how to manage this? You can have fluorine treatment. Professional fluoride treatment can be done for root surface caries management. Then use of antiseptics for caries prevention. What you have to understand is chlorhexidine is not only for periopathogens. It has a good effect over streptococcus mutans also. So in that way also you can avoid caries. Then root surface plus varnishes and all can be used. Sorry. So shall I repeat?
Yeah, no, you just repeat the last sentence.
Okay. So you have a casein phosphopeptide or calcium phosphate contained in toothpaste. Like you have this GC tooth mousse or Clean Pro by 3M, or you have Inafix by Group Pharma. Okay, those can be used, and even silane-based chewing gums can be used to prevent caries in this maintenance patients. Now, next slide, sir. Okay, now the perio way of extraction, which I try to follow in my practice. So if okay, if you always if you you can practice something called an atraumatic extraction, where you cut out the crown, you split the roots, use periotomes or laxators to individually take out the roots. Okay, and coming to perio management, instead of total extraction, you can extract one of the roots, which you call a root resection, or you can extract half of the tooth, the lower molar, maybe a mesial root is fully affected. You can just resect that. It's called hemisection, or a root resection, especially the distobuccal root of upper molars. This has to be done after RCT. Okay, another this thing, if you have a if you need this root submergence is, suppose a tooth is totally uninfected, like an untreated teeth. Okay, which that need not be extracted for a FPD. Okay, what you can do is you can do RCT and you can submerge it. Suppose such a tooth is infected, like a caries involvement or whatever that matter, tooth is infected. Instead of totally extracting that tooth, you can just retain a part of the labial part of the root. Okay, it's called a pontic shield. Or if you are retaining the labial shield of root, and if you're doing an immediate implant in that, you call that a socket shield. See, now, see all the concept. All this concept is based on. Now, an extraction socket has got three modes of blood supply. You have the endosteal blood supply, which comes from the bone. You have the periosteal blood supply, which comes from the periosteum, and you have the periodontal ligament blood supply, which actually comes from the periodontal ligament space. So once the tooth is extracted, the periodontal ligament is gone. Okay, the periodontal ligament is gone and the periodontal blood supply is gone. So if you can retain that, okay, that is the concept. That is the concept behind all these concepts, all these procedures. You try to retain the periodontal ligament blood supply. What you have to understand is the apical, the crest of the alveolar, the apical 2 mm is actually only supplied by the periodontal ligament blood supply, and you will have inadvertent loss of that bone once the tooth is extracted. Okay, how much clinically significant that is, that's a different question, but this is the concept. Now, socket preservation. If at all you need to remove the teeth, okay, now what you do, you preserve the socket. Okay, now again, immediately extraction and immediately preserving the socket actually delays or that also preserves the bone loss. Okay, so any of this root partial or total root preservation procedures are not advocated, then you can go for at least socket preservation immediately after extraction. And the socket preservation is for preservation of the heart, the heart tissue. Now, for the preservation of soft tissue, you know, when the teeth is there will be a crescent shaped of gingiva. Okay. Now for preserving that, you can use an ovate pontic. Okay. Suppose you are extracting a teeth. Okay. You can use, if the crown is intact, you can cut out the root, you can modify the cervix, and you can use it as an ovate pontic after socket preservation, and you can attach with the adjacent teeth by direct bonded bridging, like splending. Okay, so that the soft tissue profile will also be retained like that. Okay, now whenever it is possible, whenever it is possible, always try to go for an immediate implant placement. Okay, and sometimes after extraction, you need to do some soft tissue or hard tissue augmentation. Okay, that also you can do along with the extraction procedure unless it is infected. Okay, fine. Now the next slide, please. Now again, see, I have a concept of a periodontal way of everything, a periodontal extraction or periodontal restorations. Now, an important concept is deep margin elevation. Now, I'll be called to different clinics for doing a crown lengthening, for the matter of placing a crown, or for giving a proper post-endo restoration, restoration or anything. So many times I'll be called for remove crown lengthening, either at the labial or lingual or palatal surface or interdentally. So, but now what I tend to do is, instead of making a supragingival margin, a subgingival margin supragingival by crown lengthening, what I do is I try to shift, or I try to elevate the subgingival margin into a supragingival margin restoratively. Instead of, I'll repeat it, instead of trying to make a subgingival margin supragingival surgically, what I tend to do is I try to elevate the subgingival margin supragingival restoratively. Now, many prosthodontists will have a difference in opinion. So, as I already mentioned, you have a concept of giving the tooth restoration margin at necessarily on the tooth surface, on intact tooth surface. But what I understand from my recent experiences and from the recent literature is, see, if you are elevating a subgingival margin supragingivally under isolation and in a inflammation free way, means the that whatever part of restoration which is below the gingiva should be completely polished, should not cause any kind of inflammation. See, the soft tissue, especially the epithelium, acts the same way, whether it is cementum, whether it is enamel, whether it is composite, whether it is polished metal. Okay, other than the ceramic, it acts the same way. It doesn't matter. It should be sound tooth structure, cementum or enamel. Even if it is a well finished and polished composite restoration, the biological width will not feel violated. The biological width will never feel violated. So this is the main problem, and many people will confuse it, think that when you do a restoration subgingivally very close to the bone, you're actually violating the biological width, provided you do it under isolation with utmost care, with finishing polishing protocols, which I follow, the recent injection molding techniques and all those things are there. So if you follow that, a deep margin elevation is of course better than a crown lengthening procedure for prosthetic or restorative reason, and especially in the interdental area. I mentioned earlier, you cut away bone or soft tissue labial or lingually, it's okay. But interdentally, if you violate the biological width, you will definitely encounter with black triangles or gingival recession later. Okay, so especially in interdental areas, instead of crown lengthening, you always try for deep margin elevation, be it posteriors or anteriors. So one of the case of deep margin elevation, this is done with super bond, the same material which I use for splinting. Okay, this is an experimental case, and the tooth is after 1 year it is going good. Hopefully we'll have another discussion to more where I can show my cases. Here I didn't want to promote myself or show my cases, but because a lot of topic had to be covered, I that's why more of clinical cases were not included. Okay, now next slide. Now this is another case. I told you about caries management. Okay, subgingival caries. Now this, if you manage in a normal way, never the inflammation can be controlled. Okay. Now I believe this is also the responsibility of a periodontist. It's not just about the soft tissue management. Soft tissues can be very well managed many times by doing composite restorations, okay, by doing restorative managements. Now, yeah, next slide, sir. Now coming to another thing about periodontal prosthesis, the periodontal way of prosthesis. So instead of FPDs or instead of RPDs, there is something you can do. I mentioned earlier also, along with splinting, you can do something called direct bonded bridges. You can do it with natural teeth if natural teeth is there. You can do it with acrylic teeth, you can do it composite teeth, you can do it with fractured crowns. So all these modalities, especially in a periodontally compromised condition where the adjacent teeth are mobile and not periodontally good to act as abutments, or even for an RPD, it won't be able to efficiently work as the clamp teeth, like the adjacent teeth which support the RPD. You can very well go for a direct bonded bridge. Okay. Now another concept is verteprep, which is another upcoming concept. I find it personally, because I'm not, I just started doing it, so I won't be able to talk more about that. But from my limited experience, I find that is the most clinically friendly, periodontally friendly tooth preparation technique. Maybe I'll be able to talk about that more in another session. Now, yeah, this is one case of direct bonded bridging which I wanted to show you. This is actually an acrylic teeth. I found this patient came to me. He lost the teeth and he came to me. Was having periodontitis. All the clinical features of periodontitis also you can see here. You can see inflammation, you can see swelling, you can see local deposits, everything. And he had a fall. That's how he lost his teeth, just already periodontally compromised. So I took a acrylic teeth, matching acrylic teeth, made it into an ovate pontic. His all adjacent teeth were also mobile. So I splinted that with superbond. Along with that, this teeth was used, made it an ovate pontic, and directly bonded, a direct bonded bridging was done along with splinting of adjacent teeth. Okay, I have many more cases of splinting or direct bonded bridges, which if whoever interested, I'll be sharing in the group. Okay, I because that I need to talk more about that, and because of time limitations, there are a lot of I know this lecture has gone little more into the theory, and but that was necessary, I felt, because a lot of topics had to be covered. Now how we can make it more useful is all try to be in the group, the WhatsApp group, where I will share more of clinical cases and we can have more of clinically oriented discussions. Now because the basic theory part is clear, now we can have more of clinically oriented discussions by sharing our cases. Okay, this is another case of, okay, these are all patients complaint. They will not come to you for periodontal management. Their problem will be spacing between teeth. She was a PhD scholar who actually had a splinting done. She did ortho treatment thrice, and she will not do scaling because she's after scaling she gets her embrasure spaces opened up and she gets this spacing, and she was afraid of scaling. But such patients, what you can do is, there are a lot of restorative managements that you have to do. This is done. Space closure was done with BioClear injection molding, anterior injection molding plus splinting. This splinting was done. This is an immediate post-op. Okay, before finishing and polishing is done, which was she was recalled later and recalled for finishing and polishing later. And this is a retracted photo. The smiling photo is much better. Okay, so maybe I'll share that photo later, which I don't have with me currently. Now, these are all different ways to actually. So it is not just about periodontal management. Okay, fine. So some more clinical pictures I wanted to add. These spaces were left for that, but because of some other technical thing, I was not able to do it. Now, this is my way of periodontal management. Now, these are the references. Now, thank you all for patient listening. I know this has gone too far. I mean, there were a lot of theory and a lot of breaks in between. And because I was not operating the PowerPoint presentation on my own, there were some confusions. Now, this ends the presentation. Now we are open to queries. I think we already have few queries.
Yes.
I'll
read it to you, doctor, if you want.
Yes, sir. Yes.
Thank you. First of all, thank you, doctor, for this such an extensive and elaborate and very any good class.
Did it become too much elaborate? I mean,
yeah, it is. It's elaborate, but it is good. We could brush up our knowledge.
That is what, sir. I thought like now the participants.
Yeah.
Participants can actually come into the group, the WhatsApp discussion group. I can discuss. I can post more of clinical cases. Now, since the theory is kind of done, we'll be able to discuss more cases in that.
Yeah, surely we can do that. No problem in that. And moreover, it's on YouTube. Those who have missed it can watch it on YouTube itself. The recording is there. It's live on YouTube actually.
Just give me a minute of break. I'll just come back and be ready for your answering your queries, sir.
Yeah.
Okay, sir. Okay.